fibrillation, which is a very important cause of irregular narrow QRS complex tachycardia. So irregular RR interval, here you have the RR interval, so far you have the RR interval which was regular, so you are diagnosing a regular narrow QRS complex tachycardias. Here the RR interval itself is regular and there is no well-formed P wave. Here the ventricular fibrillation, atrial fibrillation, the atrium is fibrillating. It is actually fibrillating like this. There is no coordinated atrial depolarization. Because there is no coordinated atrial depolarization, you would not find well-formed, nicely formed atrial depolarization in atrial fibrillation. So the criteria to diagnose atrial fibrillation is absent P wave, irregular RR interval, and fine fibrillary waves. This fibrillation will produce a fine undulating baseline, which is called fibrillary wave. So there are three criteria to diagnose atrial fibrillation: irregular RR interval, absent well-formed or well-coordinated P wave, and the presence of fibrillary wave. So here what happens is, in atrial fibrillation, multiple areas in your heart, in the atrium, is producing small impulses, small fibrillary impulses. So the whole atrium is fibrillating like this, producing a atrial rate of more than 400 or 500 per minute. Once again, it is AV node. What the AV node does is, whereas in atrial fibrillation, the AV node is because it is a regularly occurring P wave, the AV node was conducting some third impulse or fourth impulse to control the heart rate. Whereas here, the atrium is beating and all sorts of atrial impulses are coming and bombarding the AV node. So the AV node is confused. So what that does, it allows one beat and stops one beat, allows two beats and stops three beats. So because of that, your RR interval is irregular, because the AV nodal conduction is irregular, because your atrial fibrillation impulses are so irregular and they are bombarding the AV node in different areas and different portions. So some beats are conducted by the AV node, some beats are blocked by the AV node in an irregular manner. That's why your RR interval is irregular in atrial fibrillation. So that's why once again it protects the ventricle, because even in atrial fibrillation, your RR interval is going to be, your QRS rate is going to be 150 or 160 per minute. So it may not be allowing all the 300 impulses, but it will not be having a regular RR interval, regular conduction, because of the highly irregular atrial depolarization fibrillary wave which are happening. So look at this ECG here. You can have, once again, a heart rate is faster. So you know it is a tachycardia, and your QRS is less than 120 milliseconds. You know it is a narrow QRS complex tachycardia. See the RR interval. See the RR interval here. See the RR interval here, 3 squares, here 2 squares. Right? See here it is 2 squares, here 3 squares. So see the constant variation of RR interval. So the RR interval is not regular in this ECG. So the whole RR interval is irregular, and you now have well-formed P wave. Is there any well-formed P wave? There is absolutely no coordinated atrial depolarization. Instead of that, you have, see that fine undulating baseline, small serrations. So this is the fibrillary wave. So the presence of fibrillary wave, irregular RR interval, and absent of well-coordinated P wave depolarization is the diagnosis for it is required for the diagnosis of it. You can see the RR interval here. Here RR interval little longer here, shorter here. See, each RR interval is keep on changing. So irregular narrow QRS complex tachycardia is atrial fibrillation. Most common arrhythmia in many of the situations like rheumatic heart disease, hypertension, and LV dysfunctions, and all these things, atrial fibrillation is a very common arrhythmia. So how to calculate the rate in atrial fibrillation? For the rate I told you previously, when you have this 300 and 1500 calculation, it is only for regular rate. But in atrial fibrillation, if you apply this rule, it will be 150 here, 100 here, 110 here. So each RR interval will have a different rate. So you cannot apply the same rule for atrial fibrillation. For that, we have a separate calculation to calculate the heart rate, for which you must do, you can take the rhythm strip. The rhythm strip is the one where you continuously record the QRS complexes in a given single lead. So what you must do is, you mark one big square and take 30 big squares. From here, you count 30 big squares and mark again. So 30 big squares is how many seconds? 30 big squares is how many seconds? 6 seconds. 0.2 into 30 is 6 seconds. So now you have marked what? 6-second period, isn't it? Now you have marked by 30 squares, you have marked 6-second period. So count how many QRS complexes you have it in this 6 seconds. Right? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 17 and 18. So let us imagine there is 20. So let's imagine for practical purposes it is 20. There are 20 QRS complexes in 6-second period. What is the average heart rate? 6-second period you have 20 R waves. So what is the heart rate? Yes, 6 into 10. For 1 minute you multiply this QRS complexes in 10, it is 200 per minute. So this is how you calculate the average heart rate in atrial fibrillation. So in atrial fibrillation you mark the areas of 6 seconds by taking 30 big squares and count number of QRS complexes in this 30 seconds and multiply into 10 will give you the heart rate per minute. So it's very simple. In regular heart rate, you counted the squares in between the two R waves, isn't it? You counted the squares between two R waves. Whereas in irregular heart rate, you count number of QRS complexes in between the squares. In between two squares, you count number of QRS complexes. There you counted the squares in between two R waves. So this is how you calculate the heart rate. So here it is 15. Actually, we counted it's 15. 15 into 10 is going to be the 150 per minute is going to be the average heart rate of the atrial fibrillation. So 30-second period, 30 square period, 6 seconds. 6 seconds have got 15 QRS complexes. So 1 minute will have 150 per minute. So in atrial fibrillation, you not only diagnose. So once again, you can see this is a classical ECG of atrial fibrillation. See the fine fibrillary waves. See the small undulating baseline. So this is a fibrillary wave. So there is no well-formed atrial depolarization. So this is a classical absent P wave, irregular QRS. You can see the 3 squares there. You can see 6 squares there, and you see once again 6 to 7 squares there. So it's completely irregular QRS, absent P wave, presence of fibrillary waves. So once again another important area where you have the fibrillary waves here. So atrial fibrillation. So normal atrial fibrillation, when you calculate the heart rate, you not only diagnose atrial fibrillation, but you must also mention whether you have a controlled ventricular response, fast ventricular response, or a rapid ventricular response, or a slow ventricular response. So when the average heart rate you calculated is less than 60 per minute, it is slow ventricular response. If it is 60 to 100 per minute, it is called controlled ventricular response. 100 to 140, it is a fast ventricular response. More than 140, it is rapid ventricular response. So according to that, this is average heart rate, not by the regular this thing. 6-second period, how many QRS is there? Into 10. That gives you the average heart rate per minute in atrial fibrillation. So when that rate is like this, you not only diagnose in atrial fibrillation, you must always add what is your ventricular response, whether it is regular, constant, whether it is controlled, slow, fast or rapid. So depending upon the average heart rate per minute. So as I told you, the commonest cause of atrial fibrillation is rheumatic heart disease, especially involving the mitral valve, either the mitral stenosis or regurgitation, resulting in a very large left atrium which produces the tachycardia. So the treatment of atrial fibrillation, we have two methods of treatment. One option is to control the rate only, which is called rate control. You keep the atrial fibrillation as it is. You are trying to control the ventricular rate only, which is called rate control. Whereas you want to control the atrial fibrillation and you want to get the sinus rhythm back, it is called rhythm control. So there are two modes of treatment for AF, rate control and rhythm control. You try to have a rhythm control only when the patient has got a long-standing, only controlling the ventricular without getting rate control. It's actually reversed here. So the rhythm control is conversion to sinus rhythm, and the rate control is to control the heart rate in the long-standing atrial fibrillation. For example, if you have a patient who is in rheumatic heart disease, a large left atrium, atrial fibrillation is there for many years, there is no point in getting a sinus rhythm because the basic substrate of dilated left atrium you are not addressing. So once you convert a sinus rhythm, the patient will go back to the atrial fibrillation because of the dilatation of left atrium. So in a long-standing atrial fibrillation, you will get only the rate control by giving digoxin, verapamil and the beta blockers. So these are the three drugs which will control the ventricular rate but keep the atrial fibrillation as it is. For example, in certain situations you are definite that 2 days back I saw he is in sinus rhythm, today is coming to me with atrial fibrillation. You know the atrial fibrillation is definitely recent onset atrial fibrillation. It is not long-standing atrial fibrillation. Then you can attempt a rhythm control, getting back the sinus rhythm, and it is done by amiodarone. The pharmacological drug which will convert the atrial fibrillation to sinus rhythm is the rhythm control. That's why don't give amiodarone in all atrial fibrillations. If the atrial fibrillation is recent onset only, you must give amiodarone. If the atrial fibrillation is long-standing, if you convert that atrial fibrillation to sinus rhythm, during the atrial fibrillation, patient would have formed a thrombus in the left atrium. When you convert that into sinus rhythm, patient will embolize from the contracting left atrium into the systemic circulation. So that's why if you are not sure about the duration of atrial fibrillation, what you must aim is only the rate control. If you are very sure about recent onset atrial fibrillation, then you will the attempt a rhythm control by drugs like amiodarone. So don't routinely give atrial fibrillation for atrial fibrillation amiodarone. So you have to make sure what is your aim to control the rate or rhythm. So always you have to give oral anticoagulants when you treat the atrial fibrillation, because atrial fibrillation, the fibrillary left atrium will predispose to thrombus formation, especially in the left atrial appendage. The thrombus will be forming in left atrial appendage, which the important danger of atrial fibrillation is embolic manifestation. So always add oral anticoagulants in patients with atrial fibrillation. So if you see the arrhythmias and the drugs we use to control them, if it is a re-entry mechanism, whether it is an re-entry tachycardia or reciprocating tachycardia, your adenosine and verapamil or vagal maneuvers will terminate the tachycardia. Carotid sinus massage, adenosine, verapamil will control and convert that into sinus rhythm. Whereas it is an automatic arrhythmia like atrial flutter and atrial tachycardia, all these drugs will only slow the ventricular response and may not convert that into sinus rhythm. Whereas only in the atrial fibrillation also, all these drugs will reduce the heart rate or reduce the ventricular rate without converting them into the sinus rhythm. So that's why the importance of using the drugs and identifying the mechanisms by which you know when I am giving this drug what I am going to achieve in this tachycardia, in this drugs, in this arrhythmia, what these drugs are going to achieve depends upon the mechanism of tachycardia. So this is the approach to the narrow QRS complex tachycardias. It can be regular or irregular. Regular tachycardias are sinus tachycardia, most common and most difficult. Find out the cause and treat. Don't treat sinus tachycardia straight away. Then regular tachycardias can be junctional tachycardias or atrial tachycardias. Atrial tachycardias will be preceded by an abnormal P wave. Junctional tachycardias will not be preceded by the P wave. There are two mechanisms for junctional tachycardias: AV nodal re-entry and reciprocation, depending upon whether you have a retrograde P wave is present or not. Retrograde P wave is present, it is reciprocating tachycardia. Retrograde P wave is not present, it is AV nodal re-entry tachycardia. The importance is to use an amiodarone if you think it is a reciprocating tachycardia. Whereas the tachycardia is preceded by a P wave at a relatively rapid rate like 200 or 250, less than 200, 150 to 280, it is atrial tachycardia. Whereas the atrial death is very fast, 300 per minute. The P waves are going to come in succession, forming a classical sawtooth appearance. So this is atrial flutter. So when there you have no formed P wave, the RR interval is irregular and there is a fibrillary wave, it is atrial fibrillation, narrow QRS complex, irregular tachycardia. The importance of atrial fibrillation is to calculate the rate by taking the 6-second period and multiplying into 10. So, controlled response, slow response, fast response, rapid response. Commonest cause is rheumatic heart disease. The treatment is depending upon the duration of atrial fibrillation, recent onset, rhythm control, duration is long and the duration is not known. With the presence of a basic structural heart disease, it is rate control. For rate control, it is digoxin, verapamil and beta blockers. For rhythm control, it is only amiodarone. So always add oral anticoagulants when you treat atrial fibrillation. So this is an approach to a patient with a narrow QRS complex tachycardia. This is the most difficult aspect of wide QRS complex tachycardia. So the wide QRS complex tachycardia are defined as a tachycardia which is once again occurring regularly but having a wide QRS complex. As you can see that the QRS complex is wide. So here it occupies more than 120 milliseconds. So when this QRS is wide and occupying more than 120 milliseconds, this is called wide QRS complex tachycardia. So tachycardic rate is more than 100 per minute, but the QRS duration is more than 120 milliseconds. Then it forms a wide QRS complex tachycardia. The wide QRS complex tachycardias, most often we think it's a ventricular tachycardia because a beat arising from the ventricle is going to depolarize the ventricle at a very rapid rate, going through a anomalous pathway or the non-specialist pathway. So a beat arising from the ventricle is going to have a wide QRS complex tachycardia. This is understandable. But important thing is, once again, the wide QRS complex tachycardia is divided into regular wide QRS complex tachycardia or a irregular wide QRS complex tachycardia. The regular QRS complex wide QRS complex tachycardia can be a ventricular tachycardia most often, but a supraventricular tachycardia with a pre-existing bundle branch block and a tachycardia through the accessory pathways are the differential diagnosis for wide QRS complex regular tachycardia. Whereas irregular wide QRS complex tachycardias are the three: atrial fibrillation with a pre-existing bundle branch block, atrial fibrillation through the antidromic pathway, and tarsal. So when you have a beat arising from the ventricle, because this beat is going to depolarize the ventricle through the non-specialist conduction system, the ventricular tachycardia will have wide QRS complex tachycardia. But ventricular tachycardia is not the only reason for wide QRS complex tachycardia, because let us imagine the patient has got a bundle branch block. Basically, when the patient has got a bundle branch block, the sinus rhythm will show what? Basic QRS. What is the basic QRS in bundle branch block? It is wide. Let us imagine this patient is developing an AV nodal re-entry tachycardia or atrial tachycardia or a supraventricular tachycardia of any origin, and this supraventricular tachycardia is going to come through the same pathway as the sinus node, isn't it? Already the sinus impulse is going with the wide QRS. So similarly, any supraventricular tachycardia with a pre-existing bundle branch block will have wide QRS complex tachycardia. Remember, understand this point. Basically, in a bundle branch block, your sinus rhythm itself is a wide QRS. This fellow develops a supraventricular tachycardia. Although it is supraventricular tachycardia, because of the pre-existing bundle branch block, this tachycardic impulse will go through the intact bundle and come through the next ventricle through the muscle. So although it is a supraventricular tachycardia, you will have wide QRS complex tachycardia. So this is called supraventricular tachycardia with aberrancy, with a pre-existing bundle branch block. Whereas these things I already told you, antidromic tachycardia. A tachycardia coming through the accessory pathway in the anterograde conduction, going retrogradely through the normal pathway, because this accessory pathway is connecting through the muscle and subsequent depolarization is through the muscle. So although it is a supraventricular tachycardia, because it is coming through the accessory pathway and getting conducted through the muscle subsequently, this tachycardia also will have wide QRS complex tachycardia. So ventricular tachycardia, supraventricular tachycardia with a pre-existing bundle branch block, and antidromic conduction through the accessory pathway are the three important differential diagnoses for wide QRS complex regular tachycardia. Luckily, 81% of times the wide QRS complex tachycardia is ventricular tachycardia. 14% of times it is SVT with aberrancy, and only 5% of times it is the antidromic tachycardia through the accessory pathway. So the commonest of wide QRS complex regular tachycardia is ventricular tachycardia. But please remember, the important differential diagnosis is the SVT with a pre-existing bundle branch block. So differentiating a wide QRS complex tachycardia from these two things is the most difficult thing in entire electrophysiology. Even an expert electrocardiographer will have a doubt whether it is SVT or VT. SVT or VT. Although we have so many electrocardiographic signs, still in a given patient, sometimes it is impossible to diagnose whether it is VT or SVT with a pre-existing bundle branch block. Then we have to differentiate whether the tachycardia is sustained or non-sustained. Sometimes the tachycardia will run for a few beats and it will automatically stop. Then the regular rhythm will be there. Then you have number of tachycardic beats, spontaneously stops, sometimes sinus rhythm, like that. So when the tachycardia is not lasting more than 30 seconds, it is called non-sustained tachycardia. Whereas the tachycardia may run from the beginning to the end continuously without a break, without any intervening sinus rhythm, it is called sustained tachycardia. Sustained tachycardias occur more than 30 seconds, it is sustained tachycardia. So it could be SVT with aberrancy, VT or antidromic, one classification. Sustained or non-sustained is the second classification. And as you can see it here, in L2 or given single lead, all your QRS complexes are of same configuration, isn't it? In a given single lead, all your QRS complexes are same configuration, meaning this tachycardic beat is arising from a single focus. This is called monomorphic white QRS complex tachycardia. Monomorphic because a single impulse. Whereas here you can see it is a white QRS complex tachycardia. Each one of your QRS complex is different. Each one of the QRS complexes, the width is different, the amplitude is different, the direction is different. So this is called the polymorphic ventricular or polymorphic white QRS complex tachycardia. This is polymorphic because each one of your QRS complex is different, whereas here it is monomorphic because all your ventricular complexes in a given single lead are having the similar configuration. So the three important classifications are SVT with aberrancy, VT, monomorphic, polymorphic, sustained, non-sustained. So these are the differential diagnosis. Then another important classification is to see whether it is a right bundle branch block type of white QRS or a left bundle branch type of QRS. As you can see here, it's a white QRS complex, all right. But see the V1, V1 is like, V1 positive wave is like what? RBB type. Whereas V5, V6 positive is what? It is LBB type. So it is a V1 negative is LBB type of ventricular tachycardia or white QRS complex tachycardia. V1 positive is RBB type of ventricular or white QRS complex tachycardia. So RBB type and LBB type. So the approach to diagnosis is the one where we are going to differentiate between the ventricular tachycardia and SVT with aberrancy. So why it is important? Why should we break our heads to diagnose SVT with aberrancy versus VT is this. So almost all white QRS complex tachycardia due to ventricular tachycardia, the differential diagnosis includes a variety of SVTs with aberrancy, and that's why the diagnosis is difficult. Many of the diagnostic algorithms are more complex and not easy to follow. It is because urgent and correct therapy is often required. Most often these patients are hemodynamically unstable. They can deteriorate any time. So the first treatment should be correct and urgent. So for that the correct diagnosis is important because VT requires certain drugs, SVT requires different drugs. So you cannot give drugs for SVT for VT, VT for SVT. So therapeutic decisions are further complicated by the risks associated with giving therapy for an SVT to VT. Like you give a digoxin or a verapamil to a VT, it is highly dangerous for a white QRS complex tachycardia. So that's why this is a challenge whenever you come across a white QRS complex tachycardia. There are a lot of clinical clues when you have a white QRS complex tachycardia. If the patient is elder, it is most often VT. Patient is younger, it is most often SVT. If the patient has got a myocardial infarction, previous history of myocardial infarction, 95% of times it is VT. You need not do any other ECG reading or ECG pointers for VT or SVT. Basic structural heart disease like myocardial infarction, cardiomyopathy, significant LV dysfunction. The patient is coming to you with a white QRS complex tachycardia. It is most often VT, whereas SVT with aberrancy happens most often in normal hearts. If the patient has got a family of sudden syncope and sudden death, it is most often VT. And the patient is on drugs which will prolong QT interval, like certain antiarrhythmic drugs of 1C or class 3, or drugs which can produce long QT intervals, like your cisapride or macrolide antibiotics. The known drugs which can produce a long QT interval, and the patient is on tricyclic antidepressants, and the patient is coming to you with white QRS complex tachycardia, it is VT. If the patient has got ECG and the previous ECG shows a pre-existing bundle branch block or a pre-excitation syndrome, it is most often SVT. If the patient has got electrolyte problems like hypokalemia or hypomagnesemia, It is most often polymorphic ventricular tachycardia. And as I told you, if the patient has got regularly occurring Cannon waves, that is the frog sign, regularly occurring Cannon waves, it is David-Roder reciprocal tachycardia. Whereas ventricular tachycardia is supposed to have an atrioventricular dissociation. So here you have an intermittent and irregular neck pulsation. Whereas here you have a regularly occurring neck pulsation. And varying intensity of S1 is a sign of atrioventricular dissociation. So during a white QRS complex tachycardia, your S1 intensity is varying. It is a pointer of AV dissociation. It is VT. And of course, when they have a beat-to-beat variation in systolic blood pressure because of the differential different portions in which the atrial beat is falling, then it is ventricular tachycardia. So there are three clinical signs of AV dissociation: varying intensity of first heart sound, irregular occurring Cannon wave, and beat-to-beat variation of systolic pressure. Then you know this white QRS is having an AV dissociation, so it is VT. Structurally abnormal heart like myocardial infarction, it is VT. Then the drugs and electrolytes, it is VT. So a lot of clinical pointers before you take an ECG and see are available to you to diagnose SVT versus VT. Hemodynamic stability or instability does not differentiate VT from SVT with aberrancy. Please remember that. We always have a mindset that the VT patient will be in shock and SVT patient will be hemodynamically stable. But it's not so. A patient with a SVT can come to you with a shock and patient with a VT can walk into your room. So hemodynamic stability or instability does not differentiate whether it is SVT or VT. So don't depend upon the hemodynamic status of the patient to differentiate between SVT and VT. So there are three types of ECG signs. Which sign you want? EC signs, not so EC signs, but difficult signs. EC signs, right? So we have first EC signs. So the easiest sign to differentiate VT versus SVT is look at the width of the QRS itself. In white QRS complex tachycardia, your QRS complex is very big, very wide. It occupies more than 4 squares, 140 to 160 milliseconds. It is VT, right? Very easy. Is it difficult? You look at the QRS width. The QRS width is 4 squares, 3 or 4 squares and more, it is VT. I tell you about the concordance, but always compare the sinus rhythm ECG. It's always, if you have a sinus rhythm ECG, always get the patient's previous ECG and compare it with the tachycardic ECG. So sinus rhythm ECG comparison gives you very important clues to diagnose VT versus SVT. So look at this ECG. This is narrow QRS complex, regular tachycardia, isn't it? Yes, right. I'm just checking all of you are sleeping or not. Right. This is a white QRS complex, regular tachycardia. So look at the QRS. What is the QRS? It's so broad, isn't it? So one QRS itself is occupying one big square. The QRS duration is 0.2 seconds. So when your QRS is so wide, SVT with aberrancy cannot be. So it is VT. So QRS width is the first point. Second, you look at the QRS from V1 to V6. V1 to V6. When V1 to V6, all my QRS complex is positive. Isn't it? Normally it doesn't happen, isn't it? For example, it is bundle branch block. V1 will show terminal delayed positivity. V6 will show terminal delayed negativity. So one positivity and negativity should be there if it is a bundle branch block. So SVT is getting with bundle branch block, you must have a classical bundle branch block pattern. After all, sinus rhythm is going with the bundle branch block. The same configuration the SVT will have. Whereas you cannot have V1 also showing positivity or V6 also showing the same positivity. So this is called positive concordance. Concordance means all your complexes from V1 to V6 are totally positive. There is no positive and negativity. Most often in a bundle branch block it will be one is positive and the other thing has to be negative because opposite direction of your impulses will produce positive and negative. So this is called positive concordance. See, V1 to V6, everything is positive. It could be a ventricular tachycardia, but most often this is called negative concordance. That means V1 to V6, all your complexes are negative. Absolutely, there is no positive wave at all. Everything is negative from V1 to V6. When you have, this is called negative concordance because all your complexes are negative. So whenever you have negative concordance, it is VT. 100% of times. Whereas positive concordance 90% of times. Whereas negative concordance is like this. All your complexes are negative V1 to V6. It is ventricular tachycardia. So the second easiest point is concordance. First is duration. Second is concordance. Is that difficult? So easy, isn't it? Then compare with the previous ECG or the sinus rhythm ECG. 3 points. Sinus rhythm ECG with the 3 points. If the patient has got the white QRS, basically in sinus rhythm, compare what is the width of white QRS in sinus rhythm, what is the width of your white QRS complex tachycardia. 1 point. Second is if the patient has got a ventricular premature beat, what is the ventricular premature configuration and QRS configuration during the white QRS complex tachycardia. See what bundle branch block the patient has got. I give you some examples. So this is basically the patient's in sinus rhythm, isn't it? In sinus rhythm, you find that what premature beat is this? Ventricular premature beat. So now you diagnose the patient basically when you compare the sinus rhythm, is got a ventricular premature beat. During the white QRS complex tachycardia, the configuration of white QRS complex tachycardia is exactly the similar of a VPD he had during the sinus rhythm. Means what it is? It is VT. So if you got a ventricular premature beat previously in sinus rhythm and during the white QRS complex tachycardia, that QRS beat is exactly the same of VPD he had during the sinus rhythm, it is ventricular tachycardia. It's so easy when you have a ventricular premature beat because you know it is coming from the ventricle. Similar configuration you having during the tachycardia means it is has to the tachycardia has to arise from the ventricle. Second, you look at the width of the QRS, a very interesting point. So here the patient has got a basically sinus rhythm. What bundle branch block he has got? Sinus rhythm here. What bundle branch block he has got? He has got a left bundle branch block. So see, look at the width of the left bundle branch block in sinus rhythm. It's almost 1/6 milliseconds. Whereas during the tachycardia, you can see that during the tachycardia, white QRS complex tachycardia, the QRS complex is little narrower. You see the V1 there. See the width of the QRS in V1. See the width of the QRS in V1 during the white QRS complex tachycardia. So if it is going to be SVT with aberrancy, you cannot have, the SVT aberrancy will look exactly the same bundle branch block he had during the sinus rhythm, isn't it? So during the tachycardia also, your width of the QRS complex will be the same as during the sinus rhythm. Whereas here, the width of the QRS complex is changing during the white QRS complex tachycardia, means it is VT. So in nutshell, if the QRS complex is narrower than the basic QRS complex in sinus rhythm, it is VT. Because if it is SVT with aberrancy, it will be the same QRS in sinus rhythm, it will be the same QRS width in during the aberrant conduction during the tachycardia. So QRS complex is narrower than the basic QRS, it is VT. Then you look at this. Here, the patient has got clinically, this is a sinus rhythm ECG. You look at the L1 there, sinus rhythm ECG, L1, what bundle branch block there? L1, what bundle branch block? V5, V6, what bundle branch block? Yes, louder. V1 is down, V1 is negative, V5, V6 is positive. What bundle branch block? Left bundle branch block. So this is a left bundle branch block. Whereas during tachycardia, what bundle branch block he has got? See the V1? V1 is positive. So during sinus rhythm, he's got left bundle branch block. But during the white QRS complex tachycardia, he's got right bundle branch block. It cannot be. If it is SVT is going to be getting aberrantly conducted, during the tachycardia also you must have left bundle branch block. So one bundle branch block in sinus rhythm and another bundle branch block during the white QRS complex tachycardia, it is likely to be VT. Then of course you can see it here. So you can see that here once again in sinus rhythm there. So what bundle branch block here? V1 negative, V5, V6 positive. What bundle branch block? Left bundle branch block. So during the tachycardia also is got left bundle branch block. So if it has got a same bundle branch block during the sinus rhythm and during tachycardia, it is likely to be SVT. Whereas it's got one bundle branch block in sinus rhythm and other bundle branch block during the white QRS complex tachycardia, it is likely to be VT. So comparing the sinus rhythm is three important areas. Look at the VPD and look at the configuration of white QRS complex. Is it same? It is VT. when QRS complex width is different from the basic QRS complex width in sinus rhythm, it is VT. Whereas patient has got one bundle branch block in sinus rhythm and another bundle branch block pattern in during the white QRS complex tachycardia, it is VT. If it is same bundle branch block during the sinus rhythm and during white QRS complex tachycardia, most often it is SVT with aberrancy. So these are the three important signs. There are not so easy signs. They are not so easy signs. I want to concentrate only on one point of atrioventricular dissociation. I will not tell you difficult signs. I will not tell you not other so easy signs. So this AV dissociation is very, very important to diagnose ventricular tachycardia. So what's happening is, for example, if the heart rate is faster, for example, the ventricle is beating at a faster heart rate, at that time you must imagine that the sinus node also producing an impulse. It is not as if sinus rhythm is idle. It is also continue to produce 60 to 100 per minute, but the ventricle is beating around 150 or 200 per minute. So because of that, what happens is when the sinus node, after depolarizing the atrium, when it arrives the sinus, when it arrives at the ventricle and trying to go through the ventricles are always in constant refractory period because of the faster beating ventricular pacemaker. So ventricle is beating 200. So when the sinus node comes and sees the AV node and the subsequent conduction or the ventricle is always in refractory period. So the atrium cannot go through the ventricle at all. So the atrial beat will be going independently, the ventricular beat will be going independently. So your atrium will be governed by your sinus node and the ventricle will be governed by the ventricular pacemaker. So there will be independent beating of atrium, independent beating of ventricle. So this is called atrioventricular dissociation. So this is because sinus impulse after depolarizing the atrium cannot go through the ventricle to depolarize the ventricle. So sinus rhythm will be occurring independently and ventricular rhythm will be occurring independently. Ventricular pacemaker rhythm will be occurring independently. So that means in a normal sinus rhythm, we always find atrioventricular association. All P waves, QRS. P wave, QRS. So all your P waves so far was associated with the QRS. Whereas here, because it is a single impulse was depolarizing the atrium and ventricle. In our sinus rhythm, single impulse from the sinus node was depolarizing atrium and ventricle. So P wave was followed by QRS complex. Here the atrium is depolarized by sinus, ventricle is depolarized by the ventricular ectopic pacemaker. So because of the two pacemakers, there is independent beating of atrium and ventricle, and demonstrating atrioventricular dissociation is a very important point to diagnose a ventricular tachycardia. And you are demonstrating, by demonstrating AV dissociation, you have two pacemakers working. One is sinus and another is ventricle. Whereas in SVT with aberrancy, it is only single pacemaker again. But it is going through the bundle branch block. But it is a pacemaker is, single pacemaker is depolarizing the atrium and ventricle in SVT with aberrancy. Whereas only in ventricular tachycardia, two pacemakers are working depolarizing the atrium and ventricle. So it's a very important sign of atrioventricular dissociation. For that, what you must see is during the ventricular tachycardia or the white QRS complex tachycardia, carefully see whether there are any P waves. You see that P wave there? See another P wave which is falling just in front of the QRS here. It is on the ST segment here and it is just in front of the QRS here. So three P waves are occurring in three different portions of QRS complex, indicating that the P wave has got no relationship to the QRS complex. P waves are occurring independently and the QRS is occurring independently. So this is called atrioventricular dissociation. So if you